anyways, without further ado, so my name is Alex Chern. I'm a fellow in otology and neurotology and school-based surgery. So that's ear and school-based surgery at the Johns Hopkins Department of Otolaryngology. We were asked, Zena, who is on the board of the HLA, and I wrote this article about noise in hospitals, and it got very popular when we were asked to give a talk. Unfortunately, she couldn't be here today, but a lot of the information that I pulled for this talk is based on what we wrote in our article. So for those of you who weren't in attendance at the Diablo Valley meeting, I will tell you all a little bit about myself. So I grew up in Jacksonville, Florida. That's a picture of me and my mother. I also have hearing loss, and I've had it since I was very young. And I received hearing aids at age 7. And I grew up playing the violin, which has always been a very big passion of mine. And for no other reason other than me being a dumb adolescent, I stopped wearing hearing aids when I was 18 years old, right before I went to college. Here's a picture of me in the symphony orchestra when I was a kid. I attended Yale University and I studied molecular biophysics and biochemistry. And I also studied violin at the Yale School of Music with faculty there. They have a great school of music. I went to Vanderbilt for medical school. In medical school, I actually got hit by a car too. That's a picture of me. They did a piece about me after I recovered and everything. I'm okay now, thankfully. And this is the crosswalk where I got hit. After that incident, I started working in a music cognition lab during my recovery with my friend Raina Gordon. And I also did some work on music and alarms, and I'll bring up that work a little bit later. And I worked with an anesthesiologist named Joe Schlesinger. During this whole time during my recovery, I actually rediscovered my love for music, and I started wearing hearing aids again. This is me playing the violin for a concert in medical school. I don't think I optimized sound quality and video quality before I shared my screen. So in case it's choppy, it's not my playing, it's the video quality. So I did my residency in otolaryngology head and neck surgery at Columbia Cornell. So that's ENT surgery. And I did a lot of research in age-related hearing loss and cognition, which is a very hot topic these days, as well as hearing loss in music appreciation. And I talked a little bit about that work on a Saturday. Here are pictures of me and some of the mentors I had. Currently, like I mentioned, I'm a fellow in otology neurotology, which is ear and skull-based surgery at Johns Hopkins University. These are some pictures of me and my co-fellows, there are other subspecialty co-fellows. This is my other co-fellow, and I'd be silly in the operating room. Here is me, my fellowship director, John Carey, and some Norwegian colleagues that were visiting, posing in front of the hospital. So music and hearing loss has always been my passion, my profession, and my life. Now today I'm going to shift gears a little bit and talk about noise in the hospital. Now, when I was making this talk, I was thinking, how can I relate noise in the hospital to you all, all of us who have hearing loss? And I actually think it's actually very relevant, and it can be definitely connected. So the outline of my talk today will be, first I'll discuss how loud is it in the hospital, followed by what actually contributes to noise pollution in the hospital, and what's the impact of this noise on hospital staff and patients. I'll also discuss how we can take steps to prevent loud noise exposure in the hospital. And then finally, how is this relevant to all of us with hearing loss? So how loud is the hospital? This is a picture of Florence Nightingale. I think, some of you may have heard of her. She is the English social reformer and also the founder of modern nursing. She's a very famous nurse. She was actually one of the first individuals to write about the possible harm caused by excess noise in hospitals. She wrote, quote unquote, "Unnecessary noise is the most cruel abuse of care which can be inflicted on either the sick or the well," in her or 1859 book called Notes on Nursing. Unfortunately, today modern day hospitals are actually louder than ever. I would have thought that before I went into medicine that a hospital would be a very quiet place for healing, for those that are recovering, and for those to get some rest. That's actually not true. So the World Health Organization, the International Noise Council, and the Environmental Protection Agency, the EPA, have actually proposed noise limits for hospitals. There aren't really enforced regulations, but there are some proposed limits. Now, these range from 35 to 45 decibels for the daytime to 20 to 36 decibels at night. And I'll talk a little bit about what that might mean. There are a lot of studies that have actually found that noise levels throughout the hospital have significantly exceeded this limit. So one noise survey found that the average noise level was 50 to 60 decibels, with a trend of increasing noise levels over the past 45 years of this hospital. Another systematic review found that indoor noise levels actually range from 37 to 89 decibels. And this was based on measurements taken in the intensive care units, waiting rooms, dental clinics, emergency rooms, etc. Operating rooms can be even noisier, and noise levels can often exceed 60 decibels and peak up to 115 decibels. That's quite loud. So here are some examples of some common sounds that we hear in everyday life. So for example, in nighttime, these are outdoor noises. So quiet rural nighttime, that's about, look at this column over here, 20 decibels. Quiet urban nighttime, maybe 40, okay? When we start hitting 50, 60, 70, then we get into commercial area, lawnmower levels, which is really quite loud, okay? Some indoor equivalent to that would be a really loud business office, a dishwasher next door, a vacuum cleaner, etc. And here are some other noises, common noises that you might hear in everyday life for comparison. In a quiet desert, it may be 10 decibels, very quiet. In a quiet room, maybe 30 decibels, which is usually what the recommendation is based on those WHO and EPA guidelines for a hospital during the nighttime. When you start encroaching the 50, 60 territory, that's more like traffic outside or a busy street. And even the sound level near a motorway when you approach 70 decibels. Sometimes in the operating room, as I mentioned, it can exceed 100 decibels. So that's something like a subway, a car horn, or even aircraft at takeoff. And that's extremely loud. So what contributes to noise pollution in the hospital? So in the intensive care unit, that's what the ICU is, there's a lot of noise. There are always people having discussions, nurses, team members, rounding, discussing with patients. There's also always people coming in and out. The combined noise can get up to 75 to 80 decibels. Other sources include air conditioning, open suction. There's a lot of suctioning going on in the intensive care units. Respirators, especially when individuals have to be on the ventilator. And then other miscellaneous noises, such as different equipments coming in and out, telephones, announcements on the intercom, items falling on the floor, loud noises, equipment alarms, etc. So it makes the ICU a really busy place, according to this study, ranging anywhere from 49 decibels all the way to the 90s. The operating room, which I am in quite frequently, including today, can be quite loud. Sources of noise include suctions, pulse oximeters. A pulse oximeter, for those of you who don't know, it's a machine that couples a beeping sound to your oxygen level. So it's always on, it's always beeping. And then if the beep starts to sound lower in pitch, then that means the patient's oxygen level is dropping. That's on all the time. It's a patient safety thing, so it is what it is. But that does contribute to noise. Conversations in the operating room, cautery, which we use to cut through tissue, pumps, drills, especially in what I do a lot of skull-based surgery. There's always a lot of drilling. So imagine a dental drill drilling on bone. That's really loud. I think we've all been to the dentist, and it's even loud for us as patients. Imagine if we're doing this day in and day out. And we use a lot of metal instruments. So usually this isn't as huge of a deal, but that can certainly contribute to the noise in an operating room as well. Now these noises, if you can look here, even a suction, it can range anywhere from 55 to 59 decibels. Pulse oximeter, high 50s, low 60s. Even two people talking, 73, 79 decibels. A lot of times when you're speaking in the operating room, you're trying to talk over other commotion that's happening, other noise or drilling. So if you ever try to speak in a loud environment, such as a bar or a crowded restaurant or a concert, it's really hard and you have to raise your voice a lot. Now, there are a lot of innovations in medicine that have occurred in the past 100 years. Unfortunately, a lot of these have actually increased noise in the hospital as well. They certainly make it a lot easier for us to take care of patients and perform surgery, etc. And overall, they're a good thing, but they've also introduced a lot of noise. So, it's very unfortunate that inventions and their sounds, plus monitor alarms and conversations, and all of this really contributes to an unfavorable acoustic environment. Loud music is actually a significant contributor to noise in the operating room. Just so you all know, it's not like everyone is partying in the operating room. A lot of people actually find that when there is music playing, especially in, very smooth parts of the surgery, there are studies that show that it can help the surgeon be more efficient, help the tube dynamic, etc. But at the same time, it can also contribute to noise. A recent survey of nearly 700 surgeons conducted by Spotify, which is the music streaming service, found that up to 90% of surgeons listen to music while operating. I'll see that the surgeons I work with, the vast majority of them listen to some music. Usually we keep that at a reasonable volume, and I appreciate that. But occasionally I work with a surgeon who just blasts like heavy metal, and for me, it's quite disruptive. I have had some surgeons that I've worked with who don't listen to any music. Again, like I mentioned, there are some studies that show that music is beneficial to the operating room. However, loud music can also be distracting as well, and it can create an unfavorable auditory environment and potentially mask emergencies. I've not really seen an instance of that myself, and I hope to never see that, but theoretically it could happen, especially, let's say, if you're listening to a pulse oximeter and the patient's oxygen level is dropping, but you can't hear it over the loud music. What is the noise or the impact of noise on hospital staff and patients? This is a very relevant question. So there are studies that show that noise pollution in the hospital can be detrimental to both the physical and mental health of medical staff. It can contribute to heightened anxiety, more irritation, headaches, more frequent sleep arousal, malaise, and anywhere from up to 95% of our medical staff may be affected. Other impacts of excess noise worsen anxiety levels, decrease sleep quality, environmental stressors for patients at risk for falls. And there are studies that show that this noise can also impact physiologic measures, such as heart rate and blood pressure as well. It's actually fairly well known that excess noise can interfere with communication among the medical team. Now, this can be through several ways. So, for example, if you have excess alarm notifications, so if you think about it, the whole point of an alarm is to convey that a particular situation is urgent. So when you set your hospital alarm or when you set your alarm clock in the morning, you are telling yourself that I have to wake up now. That is, it's time to get up now. If you ever walk through a hospital, you hear a lot of beeping everywhere. Most of those alarms, they're technically all alarms, but they're not all actionable. Sometimes you just kind of let it go, but other times, they actually might need action, but a lot of times they don't. Now, imagine if you hear that all the time, you exacerbate the noise pollution in the environment. you get a situation where you have a lot of alarm fatigue. If you hear a lot of beeps all the time, you are more likely to not respond appropriately when there is an important one. So that may contribute to medical errors. Like I mentioned, 85 to 99% of all hospital alarms don't actually require clinical intervention. And this may also distract from identifying urgent situations. So we kind of run into a boy who cried wolf scenario where you hear a lot of alarms, like the boy who cried wolf, but then suddenly when the wolf actually comes, you don't respond appropriately. So how do we prevent loud noise exposure in the hospital? So there are different ways that clinicians can use to monitor noise. There are digital applications on your smartphone, like your Android and iPhone. Some of you all may have seen that already. Your Apple Watch there's a noise app to identify exposure levels to harmful noise levels. You can minimize use of instruments with loud noise that may damage hearing and discourage any unnecessary commotion. You can ask the person who's in charge of the computer to lower the volume of music. I've actually done this many times, and it's definitely appropriate, especially when you want 100% of the focus of the entire team to be at the task at hand, especially when something more urgent is going on in the case. The other thing is to enforce best communication practices. So you always want to assume at least one person will be able to hear verbal communication and maximize use of nonverbal communication. So visual cues, things like that. Minimize any background noise, like a suction that's left on that doesn't need to be on. And then in the hospital where patients are resting, to implement a music and quiet rest period protocol. Another way to help address this is to identify and invest in long-term solutions. So there are ways to optimize acoustics with design of the room. So a room with a lot of reverberation, for instance, is not an acoustically favorable one because it's very echoey. We can also supplement existing visual and auditory communication of alarm events. So there are new fancy devices now that give you haptic or vibrotactile displays as the form of the alarm. Joe Schlesinger, who I worked on some alarm and music research with in medical school, he is studying a device called the Canary Box, which was designed by an anesthesiologist out of Montana, private practice anesthesiologist named Alistair McDonald. It's actually a very interesting medical device that integrates the music playing in the operating room with vitals. So in a more urgent setting, let's say, you hear someone's oxygen levels dropping through the pulse oximeter, the volume will actually start decreasing. Not suddenly, but decreasing enough so that everyone in the room knows that, oh, something's going on and we need to address it. The other solution is to start implementing policy changes. Writing to our local senator, implementing policy changes from above and within the hospital as well. So now that I've talked about all this, how is this relevant to all of us with hearing loss? I think a lot of these ways we address noise pollution in the hospital, I think individuals with hearing loss can also take a leaf out of that book and use to optimize. We can use it to optimize our own auditory environment. A lot of you may know these strategies already, but I always think it's nice to look at things from the lens of another point of view and then taking it back and looking at our own solutions as well. So number one, use your hearing device and optimize communication strategies. I think even though we all know that we need some accommodations sometimes, don't be afraid to ask. I don't think a lot of times people don't provide accommodation, not because they don't want to. It's just because they don't realize that we have hearing loss. Hearing loss is an invisible thing. You could walk around all day, you would never know someone has hearing loss because there's no indication unless you start communicating with them. And oftentimes, if you don't hear them, they don't realize it because you're not hearing them. They just think, maybe it's something to do with their intelligence or something like that. But don't be afraid to ask. I think in general, people are usually a reasonable person is usually more than happy to help. So examples, which you all know, ask people to speak clearly while facing you, minimize background noise, use closed captioning as we are doing in this meeting. When you see physicians, especially in places where they still have a mask protocol, ask them to wear a clear mask. If you are helped with lip reading, that's very reasonable, and a lot of people will do that. If you're in a loud environment that is not a favorable environmental setting, you can ask to reduce noise. I was having lunch with my friend who's a pediatric radiologist, and it was very noisy in the restaurant, and she asked them to reduce the noise by turning down the music, and they did it, and it was no problem at all. I think the other thing that we should always do is to really embrace new technology and educate yourself. We have hearing loss, but I think it's important to always keep up to date with new technology. For example, these days, as you all know, there are hearing loops and hearing aid telecoils. I think all digital hearing aids these days have Bluetooth direct streaming, as do cochlear implants. I would learn about your iPhone and Android accessibility options. One of the audience members at the Diablo Valley meeting on Saturday, who had more of a hearing loss on one side, asked how to balance sounds on making one headphone louder than the other on the iPhone. I didn't know the answer, so I looked it up. I think it's good for all of us to familiarize each other with these tricks. People you can ask, your audiologists, they're definitely more than willing to help, and they can definitely help our education for this. And also talk to your friends who use similar devices. And then, this is a group, and we're all here for each other. And I think it's okay for us to talk to each other. And I would encourage us all to talk to each other about how we can optimize our auditory environment. Now, COVID, as you all know, I'll briefly make a segue into this. It really highlighted the difficulties of a challenging auditory environment. A lot of the audiologists that I work with, they told me that they actually had a lot of new patients come in because they realized that with mask wearing, they just couldn't really function without a hearing aid or something like that. So they really needed help. Now, COVID didn't just affect people with hearing loss, they affected everyone. Masks create an unfavorable auditory environment for everybody. Virtual meetings through Zoom or Microsoft Teams, it's well known that these meetings give you quote unquote Zoom fatigue, and you have just from having an increased cognitive load. And even a normal hearing person listening through headphones all day and staring at a screen, they will get tired because it's also not a favorable auditory environment either. So in conclusion, hospital noise pollution can be harmful, and efforts should definitely be made to create a favorable auditory environment. And as individuals with hearing loss, we can definitely take lessons from these strategies to help optimize our own hearing environment. I'd like to acknowledge Zina Jawadi, my friend, and also board member of the HLA, for helping with this piece. She's been really insightful and super great to work with. Joe Schlesinger and Alistair McDonald were two of the anesthesiologists that I worked with in the past. Alistair McDonald, the one who came up with that canary box device that I talked about. Here are my references, and I'll take any questions. Feel free to email me if you have any questions too that come up, or just about anything. I'll stop sharing my screen now.
Okay. So thank you so much, Dr. Chern. I learned a lot. And guess what? I'm getting a second cochlear implant this Friday at UCSF with Dr. Lim. I don't know if you know Dr. Charles Lim, but he's doing, do you know him?
Yeah, I do. You can tell him I said hi.
Okay.
I met Charles Lim the first time when I was a medical student. I went to a music and cochlear implant conference in Denmark. And this was 2016, I think. And when I went there, there were 3 Americans. It was me, Charles Lim, and someone named Jay Rubenstein from University of Washington. So I know him, not super well, but I say hi to him at meetings, and we've talked a few times about research and whatnot. He's really great. He's a really amazing individual, and has done a lot of work with the cochlear implant community, studying music perception in cochlear implant users. And also his other well-known area of research is he has done these functional MRI studies looking at the brain basis of creativity, where he just put jazz musicians in he has actually great TED Talks. I would encourage you all to check them out, where he puts a jazz musician in an fMRI and he has them improvise. It's really cool.
Oh, wow. So that makes me think about what the operating room will be like, when they put me in there before they knock me out. It's a room with a bunch of people and stuff, but I have no idea how much noise is going on, or if he's going to be listening to music. I just, that's going to be his concern. But you made me think about all of that when you talked about it today.
I want to be clear. I'm not saying music is bad. Number one, if I went out and started saying that, I would be crucified by the surgical community. And that's not what I'm saying at all. I actually like music. A lot of people find music helpful, and it's not that bad at all, especially with a lot of procedures. They can be monotonous, and it's just a lot of work just to get through the case and whatnot. The vast majority of the time, it's a very reasonable thing, and it's very relaxing, and it's not harmful to our ears or the patient's ears, and it's not distracting. But I will say that I just want to raise the point that sometimes music is played really loudly, and in those cases, they could definitely be more quiet. But I'm sure Dr. Lim is going to do a great job. He's a great surgeon, so I wouldn't worry about that at all.
Okay, thanks so much. Yes, he did the other implant perfectly, so
Yeah.
I'm not worried. It was just very coincidental. So I have more questions, but let's see what questions other people have. If you could, let's see if I can see everybody here. And yes, okay, so Sue, go ahead.
Hi, I'm Sue. I'm in Utah. It's interesting that you talk about, noise pollution in the hospital. I went with my husband, who went to get an angiogram last week, and he is hard of hearing as well. And I am too. I have a severe, profound hearing loss. So I depend a lot on lip reading, and also what I can discriminate with my hearing aids. And so one of the things to advocate is, the first thing I do when I go in there, I say, we are hard of hearing. I am deaf. He's hard of hearing. And we lip read. We need you to face us when you are talking, speak clearly, give them a little spiel. And they were really good about that. The one thing that, and also we wanted the doctor to come in so we can let him know and ask about the procedure. We wanted to know step by step by step what they're going to do. Because once, you're kind of out of it, because they give you something to relax you. And because your stress level is already up there. Mm-hmm. So when you add hearing loss to it, it doubles it. But they were very accommodating. And another interesting thing that I thought was they dimmed the lights. And so when they would come in, the nurse would come in, and start talking to Bill or me, I realized I was having a harder time understanding because it was a little bit too dark. We don't hear well in the dark, right? So I asked him, I said, can you keep the light on? when you are talking to us. And then when you leave, go ahead, you can dim it. So it's interesting that it just dawned on me how lighting is important as well. In the
Yeah, no, for sure. I think thank you for that comment. I think that makes a lot of sense. I've definitely taken care of patients who, sometimes when we do skull-base surgeries to take out tumors in the skull base, they lose their hearing. It's just part of the procedure, just the way we do the approach, they just lose their hearing. So a lot of them can have trouble hearing too. And I have found that sometimes, especially in patients who have bilateral hearing loss and their hearing isn't so good, you definitely have to optimize lighting so that you can use visual cues from lip reading. I think that makes a lot of sense. And I think you're very, smart in asking for that. And I'm really happy that they accommodated you. I think, you deserve that. And I think all of us do too, for sure. So everyone do what's suited.
Can I ask one more question? Do your hospital or where you work, do you use any like hospital kits? Like do you put a sign like above the patient's bed saying, I am hard of hearing, and have like a little communication rules? Is that something that hospitals throughout the US look at, rather than just tell them I'm hard of hearing because of the shift changes,
Yeah, no, that's a good point. My hospital does do that. At Johns Hopkins, they do that. We took care of a patient recently that was hard of hearing, and there was a sign outside of her door that said that and actually informed exactly how to communicate, especially when we're waking her up, and how to wake her up and turn on the lights, etc. So, I would encourage all hospitals to do that. And if you all ever are in a hospital or in a clinic setting and you require things like that, tell them, and I'm sure they'd be happy to accommodate.
Thank you.
No problem.
Okay, Jim, could you unmute, please? Can't hear you yet. Okay, we're going to come back to Jim. Does someone else have a question while Jim is looking for his audio?
Actually, Sarah, I have a comment.
Okay, go ahead, Ann.
So, Sue, where you live, do you frequent that hospital, the hospital that you were talking about? Is that the one that you usually use? So I don't know if you, okay, so I was asking a question to Sue. Well, now I'll make my comment. So I sit on the Patient Family Advocacy Committee at UCSF. And so I wanted to make sure that other people who are here might think to ask, does the hospital that you use have a patient family advocacy committee? Because Dr. Chern, I haven't found that hospitals are very accommodating to people with hearing loss. I have heard, God knows, the most unbelievable things that were inaccurate, and there is a complete lack of understanding about what our needs are, as long as we're not deaf and use ASL. So I'm happy for you that you have such a positive outlook. Unfortunately, mine, by my experience, is not. My local hospital, which is closer than UCSF, I've been advocating there for 9 years, and I have never once gotten the accommodation I needed.
Wow. And I'm sorry to hear that. That's a shame. And I'm sure there are many hospitals and many places where accommodations are not met. And I think, I almost had an issue with that, even like working in an MRI room, and I have hearing aids, and that was an issue too, even though people with other electronic devices were able to be in their like cell phones and things like that. So, certainly there are a lot of barriers that can definitely still be addressed. And I'm glad that advocacy council has someone like you to help us, embrace or help everyone, all the hospitals really be able to help us for sure.
Yeah. So I am going to take the opportunity to talk to you later about some things I'd like to see at Johns Hopkins. So
Please.
one
Sure.
of the that I would like everywhere is when you go to the hospital's website, it's really obvious where you go and who you need to contact to get accessibility.
Mhm.
And that's not common, and I haven't seen it at Johns Hopkins either. So
Okay.
you'll be hearing from me to chat. And
No.
I don't know, are you all experiencing the screen freezing on and off here?
I think on
Yes.
on your end, I see screen freezing, but other
On
people
my
look
side,
okay.
because I have too many things open. Let me see
Um,
if I can close some.
Okay. Let's see, Jim, are you ready to ask your question? What's,
Jim, you want to type out your question and then we can just answer it if you type it in the chat box.
yes, put that in the chat. Are you able, is it in the chat yet? No, don't see it yet. Okay, okay. It says, I'm retired healthcare industry. My doctorate is in psychotherapy. I retired because I could no longer understand what my patients were saying. Now, when I go to a medical appointment, I use this card. So show us the card, Jim. Okay, hi, my name is Jim. I'm very hard of hearing. Please get my attention before speaking. Face me. Speak up, but do not shout. Speak clearly. Use gestures and point. Thank you. Oh, there's the other side. Oh, and Spanish. Okay.
Wow. That's great, Jim. I think that's a great handy card to have for sure.
Jim, I'm upset. Did you by any chance think to use a hearing loop in your space where you were talking to patients to assist for your hearing? So he doesn't. Jim, if you look in the bottom left-hand corner of the toolbar for your Zoom, you should see an icon that looks like a microphone, and yours has a red line.
And I think you're cutting out.
Okay, well, Jim's having difficulty there. You know, maybe let us know when you get the sound, Jim. But thank you so much for sharing that sign that you have. It's really great and very helpful. We have the buttons that say, please face me and speak clearly. Yours has more information. Dr. Chern, I was curious about the architecture you spoke about. What ways does the architecture influence the sound? I mean, what can they do if everything has to be so clean?
Well, so that's a good question. I think a lot of times when there's a lot of echoes in the room, it doesn't help, as I'm sure you all can probably appreciate with the reverberation. So, for example, if you were in an empty warehouse or like just a room with nothing in it, sometimes it's very difficult. But there are things that prevent reverberation, kind of like when you're, at like the symphony or something like that, and you see all those heavy drapes and stuff like that. Or there are similar types of ways to do that as well. So I would say of those things, those are the, changing the design of the room and whatnot. I think on our end, it's a little bit harder to put that into action as people with hearing loss and getting, we can't make them change the room for us a lot of the times. But I think that's one of the less actionable things on our end. But I think hospitals that are trying to optimize the acoustic environment, that can definitely be done in the future if they were thinking about designing like an ideal clinical setting.
Okay, yeah, that makes sense. And Jim is messaging us again, if you want to look at that. Let's see what he has there. Chat, my sister-in-law is a retired internist from Vanderbilt, okay? So I'm sure, Jim, she has input about that. Are there other questions that people have? Let's see. Oh, okay. So Sue, yes, please.
Well, this is a personal question to Alex. How do you function as a doctor with your hearing loss and in speaking with your patients? What kind
Well,
of accommodations do you have in your practice?
so as you all know, hearing loss exists across the spectrum. My hearing loss is, adequately rehabilitated with hearing aids, such that when I'm talking to patients, I really don't need accommodations per se, and I'm able to do okay. Hopefully, it stays that way forever. I think my hearing loss has been stable for a long time. But I do recognize, as everyone ages, everybody, even people with normal hearing now, gets hearing loss. And I think it's always good to be thoughtful of these things for the future, for sure. I think, me having experienced hearing loss at a young age and also being in the profession that helps treat these individuals have made me very partial to this. So thankfully, I haven't needed accommodations when I work with patients or when I'm in the operating room. It hasn't really been an issue. I will say that just like for most people in general, sometimes when you're in a loud environment, it can be challenging. Sometimes when I, watch a movie, I'll use captioning. The captioning always helps, I think, even for people with normal hearing, because, for example, if you're in a loud conference or a large conference, it can be hard for even people with normal hearing to hear what's going on. So I think it makes a lot of sense for captioning to exist for everybody.
Thank you.
No problem.
I see there's a question in the chat there from Nisha. Are you there? Would you like to ask the question?
It's from Nisha. Hello, how does one get into this type of research regarding hearing loss? Well, I can answer that. So different groups sometimes will send flyers through the Hearing Loss Association of America. I've done that for studies in the past. A lot of times, if they're in your local medical center, there's an otolaryngology department where there are audiologists as well. You can ask them what kind of research is going on. Sometimes there's research or they're advocating or they're asking for they're recruiting for some participants. That's one way to get involved. I would just keep your eyes open and just ask around. Certainly I will send, if I'm recruiting for any studies, I'll definitely send some flyers your way too.
Okay, let's see if there's more questions.
So my computer crashed and I was the host. So I was thinking maybe all of you got bumped off, and now I came back. So it stayed, right? Oh, I'm so glad. I was having heart palpitations over here.
Oh, okay, thank you so much, Anne. Jim, let's try again. Can you unmute?
Try again. Can you hear me now?
Yes.
Okay, I was using an external speaker microphone and going to here. I'm using the one on the actual computer now.
Great.
When I got my cochlear implant earlier this year, the end of January, my sister-in-law, the retired internist, she said in all of the time that she was in practice, she and none of her friends had ever dealt with anyone with cochlear before. So she had to go do research to find out information on it. And my question is that a common thing with practicing physicians other than those in the audiology field, or I just use the term standard physicians? They have no idea about this. And I'm glad that at least my situation was something to get them looking at it.
Jim, that's a great question. That could be true for sure. I think a lot of people, they think cochlear implants and hearing aids are the same thing. And I think part of the reason is because there are a lot of hearing aid users, right? But only a subset of people with hearing loss actually meet criteria for a cochlear implant. So it makes a lot of sense that since the prevalence of individuals with cochlear implants is very low, that even the average medical provider, they may not even know about it. It's not something that is routinely taught in medical school. I'll tell you from my own experience that, we went over hearing maybe for like 1 or 2 lectures all of medical schools. And then if you specialize through your residency training, you never hear about it ever again, unless you are, in otolaryngology head and neck surgery resident. That's the only time that you would really know. So it doesn't surprise me, but I'm glad that, she knows what it is now for sure. I think these days in the popular media, they're doing, I think, a little bit of a better job of spreading awareness about that. You guys may have heard of the movie series called Toy Story. The Toy Story 4, which came out, I think 3 or 4 years ago, there's a scene where the main character goes to kindergarten and you see a kid with the bright green cochlear implant. And I think that does great with accessibility. And then you have different, popular movies these days, Sound of Metal, which I think has its own issues, but hey, I mean, more people know what a cochlear implant is now. Coda, which has to do with more of the deaf culture, even that Bradley Cooper and Lady Gaga movie, A Star is Born. In that movie, Bradley Cooper has hearing loss. I think overall, the popular media is doing a little bit of a better job spreading awareness about hearing loss in general, and also the fact that hearing loss can occur in all sorts of people. So I think it's good. But no, what you said does not surprise me at all.
Okay, do we have any more questions for Dr. Chern? So thank you so much for being with us, and really for us and for many others in HLAA, this is a new kind of discussion where it gets into more detail about where the noise is coming from. We've heard about noise from different instruments, but not so much medical and in operating rooms and in hospitals. So we really appreciate this. And